Welcome, everyone. We'll just wait a minute for folks to finish joining us. Okay, I think we can get started. Welcome and thank you everyone for joining today's webinar. Today we have Dr. Virginia Sun presenting From Feasibility to Efficacy, Journey of a Pilot Study in Pancreatic Cancer. Just a couple of housekeeping items. Attendees are muted and video cannot be turned on. We ask that you please send your questions through the Q&A feature, which is a button at the bottom of your screen, or to engage with us in the chat. And today we also have Dr. Christine Ritchie, co-chair of the PCRC's Executive Committee. And so I'd like to turn it over to her to properly introduce our speaker.
Thank you so much, Naomi, and greetings, everybody. We're so glad to have you with us today for our May PCRC webinar. And we're also particularly delighted to have with us Dr. Virginia Sun. Dr. Sun is an associate professor in the Department of Population Sciences and also in the Department of Surgery at the City of Hope. Her research is focused on developing and testing interventions to improve outcomes and healthcare delivery for people living with cancer, along with their support persons and informal caregivers. Dr. Sun's research program is supported by the funding from the National Cancer Institute and the Patient-Centered Outcomes Research Institute. She's also done a really great job with developing partnerships across a number of different institutions and programs, including the Southwest Oncology Group and the PCRC, to name a few. And her work, which you'll hear about today, is also hopefully going to be a source of encouragement to each of you as she talks about the power of perseverance. Dr. Sun.
Thank you so much. It's great to be here. Thank you so much for the opportunity. So I wanted to spend the next 40 minutes or so to really go through this journey that I've taken on, beginning with the support from PCRC on an intervention that's focused in pancreatic cancer for patients and also now family caregivers, and also share some thoughts in terms of really the power of feasibility, conducting feasibility studies, how we can learn from it, and also how things evolve over time. And just to share some of this journey with everyone. Next slide, please. So just three, overall objectives for today really illustrate the journey of a palliative care research concept in pancreatic cancer from its origins all the way to feasibility, and now I'm trying to move it to efficacy, and some of the lessons learned along the way, and also describe next steps, because the journey continues, as you will see later on in the presentation. Next slide. So I call it a journey because even for me, every single project that I take on, when it becomes, as it starts as a seed concept, and then through pilot feasibility, and then also bring it to efficacy and sometimes effectiveness, is really a journey. For me, I think about it this way. And many of us would like this journey to perhaps be in a more of a straight line. And, we have an idea of how to, the processes, if you will, in terms of this journey. But in reality, it may very well look like these two different paths. Different paths will, you have to make choices perhaps at some certain points, and in terms of the path that you want to take, or the paths can be winding and really not so straight as you would anticipate. But I think there are lessons learned along the way. I mean, these are all possibilities in terms of the journey of a research concept, and it could very well be a straight path, but oftentimes we have a lot of points that we kind of get to where we have to make decisions and think about the design and flexibility. So I'll share some of those times and places where we need to make some of these decisions, and the paths sort of diverge, if you will, along this research concept in pancreatic cancer. Next slide, please. So just a little bit about the origin story of this concept. So this pancreatic cancer palliative care intervention really started with Dr. Betty Farrell's funded PO1 and lung cancer, which I had the very, honor to participate in. At the time that this PO1 was funded, of course, this is and being conducted, it is focused on lung cancer. We started thinking about how we can move this to other populations. And for my interest in hepatobiliary cancer, one of the first was first I was thinking about pancreatic cancer. So prior to the PCRC pilot award, we actually did, and I was an early stage investigator at that point, back in 2013, based on some of the pilot data from the PO1, we actually submitted an RO1 as an early stage investigator. And these were the results. And I'm more than happy to share results because I think it's important for all of us to see and learn that, all of us have challenges in terms of the funding. So for me, as an early stage investigator with the first RO1 all the way back in 2013, I was excited to get a 30th percentile. And then the score actually went the other direction, and we all know that is a possibility as well, with the resubmission. And at that time, because this is an RO1, we had proposed, as you can see in this study schema, a randomized trial. That's the 2-arm randomized trial of this intervention, and that's based on our PO1 grant. Next slide. And then once the RO1 sort of, wasn't at a score that was fundable, I started thinking about building blocks, thinking about maybe we need to take a step back and rethink and maybe gather a little bit more preliminary data. So a few of the things that I thought about during this time frame is, what about the, looking at the previous research and in the literature, as well as what we have done in all of our research so far, thinking about clinical observations and experiences. My background is oncology nursing, and so really diving back into those experiences and the experiences caring for this population. Looking at the current literature again, what are the knowledge gaps? And then also beginning to think about collaborators that would be great partners that could be brought into this team, and we all have shared expertise that complement each other. So kind of took a little pause and started thinking about all of these pieces to continue on with the journey. Next slide. And so we were very fortunate, and thank you, PCRC, to one of the things that we wanted to think about is getting a little bit more feasibility data. And so we were very fortunate to be funded in 2014 with a pilot award from PCRC to test the feasibility of an interdisciplinary palliative care planning intervention in pancreatic cancer. Next slide. So this was 1-year project, so we really kept our aims feasible and practical for the time frame that we were given to complete this work. And as many of you know, for pilot studies, the main focus of pilot studies, whether in my mind, whether it's sort of randomized design or single group design, and various different levels of, sample size, total sample size numbers, is really to look at feasibility, acceptability. And this is the part of the pilot study designs that I really enjoy. This is the time where we could think about the procedures, the processes, and really think about what makes everything work in terms of the delivery of this intervention. And also be able to get feedback from patients as well, participants, in terms of their experience, which I, as many of you probably believe, is very, very important. And so this is our specific aims. We were very much focused on feasibility. We wanted to look at how many patients would consent and complete the intervention. Ask our participants in terms of the timing, the content, and the delivery approach of the intervention, all the materials that went along with the intervention as well. Is the content and format comprehensible to patients? Does it make sense to them? Is it useful for them? Can they understand it easily? And then also be thinking about the infrastructure and strategy for a larger intervention trial. Next slide. So this was a single group really pre and post intervention design, again, focusing on feasibility. We really wanted to target 10 patients because that was the most feasible thing to do. We given the 1-year period, with all the startup and also IRB approval processes, and then getting staff trained, engaging the clinicians in terms of the study and enrollment. So between the startup and actually starting the intervention and then completing follow-up, 10 participants was really the most ideal number. It may seem small, but we can learn a lot from 10 patients too. And so this was our design. Our eligibility, starting here on the left side, we wanted to look at all stages of pancreatic cancer, but beginning at treatment. 21 years and older was the definition of adults. For NIH, I know now it's 18 and older. And we included several outcome measures, and these are mainly patient-reported outcomes, health-related quality of life using the FACT system tools. We wanted to look at spirituality, and so we included the FAST SB12. Mood disorders, we included HADS, and wanted to ask about satisfaction, which is part of the acceptability piece. And we did chart audits as well to look at healthcare resource utilization and asked patients a few questions related to out-of-pocket costs. So the study design was 10 patients enrolled, and then once they complete informed consent, they will give us baseline evaluation, and then they will complete the intervention, which it's palliative care planning intervention. We will do upfront comprehensive quality of life assessment using our PRO findings. Then we held, I believe this was in person, and also have phone available to clinicians and supportive care team members, interdisciplinary team care planning session where we would discuss the patient, and the nurses would present the patient, and then we'll talk about their assessment based on the PROs that were collected, and then everybody contribute recommendations in terms of what we can do for the patient by way of referrals, perhaps, and the focus in terms of the education sessions. So then the patients receive 2 patient education sessions and then supportive care referrals as needed. We did 2 evaluation time points at 1 month and 2 months. And over here in table 1, these are the session content that we really addressed. We focused on symptoms that are common in this population, as well as the common emotional, social, and spiritual well-being topics. Next slide. And so we were able to publish this finding in supportive care and cancer in 2016. So just looking at feasibility, we had screened 19 potential participants over a 4-month period, and they were invited to participate. So we really, the team really worked hard to try to engage as many patients as we can in over 4 months. And overall, we had a 58% consenting rate, 11 participants consented. We were able to retain 10 patients to complete the study. So we were able to get our final N of 10. The mean age is 65, 50% males. We had good distribution there. Not surprisingly, 60% were stage 4, but we did have a few participants that were treated with surgery as well. In terms of acceptability, this is based on our satisfaction tool. 70% rated is excellent, but we also had many patients that told us that the amount of written materials was too much. So we learned a lot from all of this feedback from patients. We knew that one of the things that we needed to tackle in the next step is the burden related to the written materials. Next slide. And I wanted to share this data too, because this also really helped us in thinking about refining our content and our approaches. So one of the things we documented as part of the study is the type of quality of life concerns that were discussed during each of these interdisciplinary care meetings. And so as you recall, we held these interdisciplinary care meetings, and the nurses presented each of the participants' quality of life information based on the PROs that were collected. So we really, hit on all the well-being domains: physical, psychological, social, and spiritual. And these were some of the topics that were most commonly discussed. Treatment side effects, not surprisingly, is the most common, and also other common symptoms such as pain, fatigue. Definitely emotional well-being was one of the topics that was commonly discussed, and the loss of appetite, eating type of discussions happen quite a lot as well. And these all made sense because of the population that we're working with. There were also a lot of discussions related to work, employment, and just being able to participate in usual activities. Next slide. And so we were able to, about the same time, be able to think about how to bring this to the next level with our feasibility trial, and find partnerships on a national level. And so at about the same time that we were finishing up with our pilot study, and then also the manuscripts and everything, in around 2017, SWOG, and I've been part of SWOG for many years. I think I started around 2015. And so there were a lot of buy-in from leadership in terms of bringing in more palliative end of life kind of research concepts. And so with the support of leadership, and I was fortunate to be part of a task force, we started actually thinking about the development and formation of an actual palliative end of life research committee. And so that started in 2017. And we were excited to say that now, all in 2019, SWOG has a palliative end of life committee, and it became a full research committee in 2019, approved by leadership, NCI, and everyone. And so this was particularly exciting because this is one of the first NCORP, National Community Research Oncology Program, research committee that was formed and successfully within SWOG. And so we were really excited that the focus is on palliative care and end of life. And so these are just some figures. Many of you may be familiar with the NCTN structure. It used to be called cooperative groups. Now it's National Clinical Trials Network. And the Palliative End of Life Committee is considered a NCI NCORP research committee. And so what that means is that this concepts that's developed through the committee can also be done within this community network. And so, and also sort of the main institutions within the NCTN. Next slide. And so we then worked, so early on in the committee formation, one of the first things was thinking about bringing concepts in. And I also want to just point out that we are so excited to have Dr. Marie Bakaitis be one of the co-chairs for this committee, and it's just amazing with her. She has been very supportive in working with us in terms of bringing this pancreatic cancer concept through SWOG. And so we were asked if we had any concepts, and I was like, yes, we do. And so here, so we were able to go through the process and approval with Marie's support and leadership support through SWOG's palliative end of life care. And this concept then evolved into a SWOG research concept. So SWOG S 2016, we were assigned a protocol number after executive leadership approval. And so that's where we're at in terms of the approval. So once within the SWOG system, if you have SWOG executive leader approval, then you are assigned a protocol number. So S 2016 is a randomized phase 3 trial. And so it's now a primary palliative care intervention to improve quality of life in metastatic pancreatic cancer patients and family caregivers. And the reason why we decided to bring in primary palliative care is because at the time the concept is being developed, there were many discussions about the need to bring, to be focusing on primary palliative care in the field of palliative care. And also our original design was very much an APRN generalist APRN kind of approach that can be trained in the basic principles of palliative care and be able to deliver the intervention. Next slide. So I am very grateful to have Dr. Vincent Chung, who is one of our great medical oncologist specializing in pancreatic cancer at City of Hope. He has also a lot of experience within SWOG, has led drug trials within SWOG as well in pancreatic cancer. So I partnered with him to really be sort of the key study team on this concept. And so I am a co-chair, and Dr. Bakaitis is a co-chair as well, in her role as the palliative care end of life committee co-chair that is helping us with the development of this concept. And of course, we have a team of biostatisticians within SWOG that helps us with the design of the statistical analyses and as well as the study. One of the key features of SWOG is that at day one, we are required to have patient advocates on board as key members of the team. And I cannot say enough about their input and their support, and also, bringing the patient's perspective. And so they review our concepts, our research design, but also give us really extensive feedback on the patient-facing materials, which has been very, very helpful. So that sort of connects with our experience from the pilot study, where we got some feedback from participants telling us that the materials are a little bit burdensome. So we were able to partner with our patient advocates and really help us think about how to better refine that component of the intervention. Next slide. So I'm just going to share a few slides in terms of how the design has evolved and things that we had to think about, on this journey from pilot study to efficacy design. So this is just a slide, as many of you know very well, that pancreatic cancer is really a population that would really truly benefit from palliative care. And the projected cancer death is going to be increasing for this population as compared to other diagnoses. Next slide. So these are some of the common complications that may impact quality of life for this population. And we also at this time went back to another one of Dr. Farrell's funded projects, which is the PC1 trial, where she brought the lung PO1 intervention, but focused on phase 1 clinical trial populations. This was an NCI funded R01. And we were able to tap into the population that were enrolled in that trial that were pancreatic cancer patients. There were 42 of them, and we're able to look at some of the symptoms data again and recognize that, again, there was a lot of physical and psychological issues, high needs, and then also consultations of multiple specialties. And from from this data, again, we confirmed there is really high unmet need. Next slide. And so our objectives for S2016 is to evaluate participant reported quality of life at 3 months in the intervention and control arms. We have a host of secondary aims to assess scores of 3 and 6 months for the symptoms. We are again using the FACT family of tools, the patient and family caregivers distress, NCCN distress thermometer, and we're also going to be looking at caregiver burden and family caregiver quality of life. So as you may recall, in the pilot study, we did not include family caregivers, but we are planning on including in this SWOG concept, because we think it's very important. And it also is very exciting to be able to include family caregivers and be able to study and learn from them on a national level. Next slide. Another secondary outcome is we wanted to look at quality metrics for our participants who died within 3 months of randomization, and we are looking at ASCO palliative quality of life metrics. And the other component that we wanted to include is to be able to do comprehensive geriatric assessment across all ages. This is something that we are already doing in many of our funded trials, and is particularly for our older adults. We're able to really be able to use this tool to tailor and personalize sort of the approach and the content that we deliver to them in the intervention. And finally, looking at hospital admission rates and overall survival. Next slide. This is our study schema. So we are focusing on patients with metastatic pancreatic cancer and their family caregivers. We will not be excluding patients who have no family caregivers. And this is a design that we put in because we think it will help with accrual and accrual at a national level across the network and within NCORP. They will be consented, complete baseline surveys, and then randomized to 2 arms, the intervention arm or the attention control arm. So the intervention arm is going to be receiving primary palliative care by an APRN plus standard oncology care. There's going to be 12 telephone sessions over 3 months, but these are divided between the patients and the caregivers. We will be really intervening with both of them throughout these 3 months, and then have a resource manual and then palliative care consultations upon request. The attention control arm will be quality of life education, so 12 telephone sessions over 3 months as well, but using the Coping with Advanced Cancer booklet, and then palliative care consultations upon request. And then at 3 months and 6 months, we will be following up with both the patients and the family caregivers. So looking at flexibility adjustments that we had to do from our original design of the trial, we thought about one of the key components in the pilot trial was this interdisciplinary palliative care meeting. Now, the ability to be able to do that on a national level is limited. And so what we had planned on doing is we will still have a care plan, which was part of that discussion and a tool that the APRNs can use. Rather than the interdisciplinary meetings, what we are planning on doing now in terms of the flexibility on the design is to still complete the care plan, but be able to, in a very secure fashion, share that with the sites and the treating team over there so that they have the information available. And the APRNs will be centrally located at City of Hope. This is another design that is most beneficial and feasible on a national level. Of course, we're still looking at efficacy, but when we get to more effectiveness implementation kind of designs, which these trials are being done within NCTN and NCORP, there may be more of a limited institution, training the institution and their staff to be able to deliver the intervention. But here we're focusing on efficacy. So the most feasible approach is to do it centrally administered. And I have some experience already doing this with another trial that I'm running within SWOG, and it has been really, really successful. Another thing that we need to think about, we thought about in this process, is the burden on the site. And this is probably something that many of you may have thought about within PCRC as well. And so to be mindful of the site staff, the site PI, site investigator sort of burden in terms of what we need to ask them to do does make a difference sometimes in terms of the success with accrual and also data collection success and everything. And so all of these things were factored into our final design, and think, in terms of the evolvement, the evolution, if you will, of from the pilot trial to the current design of the efficacy trial. Next slide. So this is again just our study population and eligibility. Metastatic pancreatic adenocarcinoma enrolled within 8 weeks of initial diagnosis of pancreatic cancer, performance status of 0 to 2. We are going to be enrolling both English and Spanish speaking patients. And this is again a design that we included because we, of course, want to be as inclusive, if you will, in terms of our enrollment. And this is actually becoming more of a focus, for all of us who are doing research, but also within SWOG. And this also will help with our accrual because many of the participating sites within NCORP or even some of the main institutions have a large Spanish-speaking population. It will make it easier for them to enroll and participate in our trial as well. We're focusing on adults, willingness to complete our questionnaires because many of our primary outcomes are all self-reported. And the family caregivers will be, or support persons will be identified by the patient. And this is our definition: a family member or friend identified by the participant and defined as a person who knows the patient well and is involved in the patient's medical care. Next slide. So again, the intervention will be centrally administered. Again, flexibility, mindfulness in terms of the site's burden, and success in terms of accrual, data collection, and really the fidelity, if you will, of the intervention. This approach from a fidelity perspective is actually very, very helpful because our APRNs will be actually here at City of Hope. Dr. Chung and I will be easily be able to work with them, provide training, and monitor fidelity. The nurses will complete comprehensive participant assessment. This is the same model that we used in the pilot study using our baseline surveys. Then they will complete the personalized care plans, which we did use as well in the pilot, based on the identified quality of life needs that participants shared with us from their surveys. And the care plans will be organized around these four quality of life domains. Next slide. And the intervention content. And so this has evolved a little bit. And so the patient content is pretty much still the same, but in terms of the family caregiver content, we are focusing on not just helping the caregiver or the support person in terms of their role in caregiving, but also would like to work with them on their own self-care plan in terms of their quality of life. So actually, the majority of our content will be, helping them in terms of their own quality of life, because we know that's important. And in terms of the information provided in the resource manual, we did streamline it as much as possible. So making things bigger font, for example, and then the content, more bullet points. So it's very easy to read, very easy for patients and family caregivers and support persons to use. For each of the topic, we will assess needs. We will talk to patients and their support persons in their strategies to talk with their care team wherever they are. We will work with caregivers in terms of their self-care tips, and then also encourage, early and continuous communication of needs with their care team. Next slide. These are just some statistics. Randomization will be stratified based on the performance scores. So we're looking at, based on our power calculations, on a need for a total of 170 valuable participants, 85 per arm. And then to account for potential ineligibility and loss to follow-up, we are aiming to have around 212 participants. I believe this number has changed, and we had to redo the calculation and moved up to about 228. So not that much of a difference. So definitely about a little bit over 200. Next slide. This is the same. Okay, so we are basing randomization, again, is on performance status, total of 170. We're looking at an 8-point difference for the FACTEP between arms at 3 months. And then the anticipated accrual completion timeframe is 4 years, assuming a minimum 4 to 5 accruals per month across all of our participating sites, with at least 10 to 15 participating sites. So in our experience, we have already engaged some of the sites working in this large network, but really the sites can choose whether they want to open this trial or not. We do engage as many as we can. So it could be anywhere from, generally it will be more than 10 to 15. My experience in my other trial is that we need at least a certain number of participating sites to be able to get the 4 to 5 accruals. For my other SWOG trial, we actually have the trial open and activating the 205 sites nationally. And this goes all the way from Maine to Hawaii. Hawaii is a minority NCORP site. So we will be able to, definitely get more than 15 participating sites. Next slide. So the next 3 slides, and I'm just mindful of my time here. The next 3 slides I wanted to share as part of our review executive level approval process. The patient advocates that are assigned to work with us and help us with a design of the protocol must provide recommendations as well. And so I just kind of wanted to share some of these things, because this was very helpful in terms of moving our intervention, our manuals, all of our patient-facing materials from the pilot phase all the way to this phase 3 trial within SWOG. So it shows the value of their recommendations, and they will, when this trial is activated, they will be with us, every step of the way to provide feedback and help us with the study process. So one of our patient advocates provided these feedback, so she did confirm that this is important for the patients and caregivers because of its convenience and personalized approach, and we did build in that piece. Next slide. Just want to point out some of the key things. They are interested and happy and agree with the quality of life as the primary endpoint and our other secondary endpoints and all the various designs that we have put in place. The telephone sessions do not seem overly burdensome. We did work very hard to work with them and make sure that it's not burdensome from their perspective for patients. One of the comments, this last bullet point, it might be helpful to have a handout for patients, support persons, family caregivers describing the study, which could favorably impact accrual. And we'll definitely be able to do that when we get to that point. Next slide. And just overall recommendations and some additional explanations. There would be interest in participation in this important study, and they do allude to our feasibility and acceptability findings. And again touched on potential barriers such as accrual and from oncologists to referrals, and that patients must rely on their physicians to inform them of the trial, encourage participation. These are all very important feedback that we will be able to work on with the SWOG team when we get to the point in terms of retention and recruitment. So we will have strategies in place to address these as well. Next slide. Just a few more patient advocate recommendations. So there are some recommendations in terms of how do you communicate with the treating team that are going to be all across the country when a symptom or sort of a specific need is raised. We have systems in place that we are going to have secure ways to be able to communicate very efficiently with the team members, and we have been able to use that successfully. And next steps, some recommendations in terms of next steps in the second bullet point, patient-centered approaches with the personalized care plans, and the resource manual being an important reference. Next slide. So this is our R1 application journey. And so we did, after we received executive level approval from SWOG and the blessing from NCI Division of Cancer Prevention, which is our steering committee, really, then we submitted an R01 in 2020. We were excited to get a score of 13th percentile. If Dr. Chung and I were both early stage investigators, we would have been funded, but we are not. And so the 13th percentile is not, is not a pay line for the, senior or more established investigators and new investigators. So we resubmitted. So similar to my first R1 experience, the scores went the other way, but it's still not horrible. We're happy to get a 24th percentile. We then submitted as a new O1 application and got a not discussed. And so I just kind of want to share that again to let everyone know that many of you may have experienced this already, but this is common, and so but it's not going to stop us in terms of continuing with our journey. So we are right now at the moment rethinking, going through summary statements, rethinking our design. Talking to leadership within SWOG, and also be able to think about new opportunities within the NCI. So the journey continues, but persistence is key. And so we are going to continue to move on with this journey in terms of securing funding so that we were able to do this trial. Next slide. So these are probably one of my last few slides because I know we're coming up to 9:40. And so lessons learned for me, some of the refinements. It's important to really be able to think about participant feedback. And one of the main things that we really worked on throughout all of these processes based on the pilot trial is the resource material streamlining. And so we will continue to be working on that with our patient advocates in our team. The flexibility in terms of your intervention design study procedures from a single site pilot study to a national clinical trial network and within the NCORP is important to consider. And it's sort of being flexible so that it's not going to completely change the intent of your intervention or your study procedures and design, but be able to actually make it contribute to its success. So a lot of our decisions that we had to make in terms of flexibility was really making sure that we can make this trial a success within a cooperative group setting. And in terms of accrual, thinking about accrual, the burden on the investigators and the site coordinators, and really, every step of the way in terms of the procedures. Again, I cannot emphasize this. This is a very important thing for me, and I think has always been so valuable, is the value and feedback from our stakeholders. And these stakeholders cover everyone, patients, families, the clinical team. I know that initially when I, with the pilot study, I really reached out to a lot of leaders and experts within PCRC, and the support there was really, really helpful. And then also now at the SWOG level. And one of the key things is to involve all of them as early as possible. And because it's really helpful to have everyone's feedback as early as possible so that your design evolves based on everyone's feedback along the way. And when it comes to funding, persistence is key. So we are not going to give up, of course, and we're going to continue to pursue funding to be able to activate this trial. I think that may be my last slide. Next slide. So yes, so perfect timing. Thank you everyone for the opportunity. I hope this was helpful, and I'd love to hear your feedback too. And my email is there if you have any questions.
Thank you, Virginia. There were so many amazing pearls in that presentation that I hope people will take away and come back to going forward. And want to start with a question. It's actually a sort of a more than one part question, so we'll try to break it down. And that is, during the feasibility stage, how did you make decisions to say, okay, this is feasible now and move on to the next phase? Like, did you consider thresholds for proportion of eligible, consented, et cetera, to be feasible? Or was it more based on other metrics? This is actually a very important question, because I think from a grantsmanship perspective, having thresholds that are communicated in your proposal can be really valuable. So go ahead, Virginia.
Yeah, and I absolutely agree with you, Christine. Our benchmark has always been about somewhere between 80 to 70%, completion of intervention, and then also thinking about, so the 80 to 70% completion of sessions, of the intervention sessions. And so I think we had, and I probably didn't share that information, but I think we definitely hit those marks in terms of the completion of the intervention sessions. And so that really guided us in terms of thinking about the ability to be able to move on. But I agree, it's very important to set these thresholds and be very clear with your definitions. And it's the definition in terms of the intervention session completion, but also thinking about your accrual. So we had a very short time in terms of accrual, in terms of the 4-month time frame, and we were successful because of sort of the collaborations that we have with the clinicians and having them on board early on. So yeah, but I agree with you, it's very important to have those thresholds very clearly defined and in place, and it will help tremendously in terms of grant applications.
Great. Virginia, I have 2 questions. One is more sort of logistical, and the other is more existential. So the logistical one is you're sort of going back to the drawing board with your latest application. What are the various pieces that you're thinking about when you get with your team? How do you sort of evaluate any kind of adaptations, revisions, adjustments to your proposal without losing its sort of soul, right? You know, so that's question number one. Question number two is, you know, I think one of the things I really love about your honesty and transparency about the process was basically showing that, you know, you don't always get a good score on the first go round or the second go round or even the third go round. And yet you've persevered. So the question I have for you is, what has helped you persevere, you know, after these sort of disappointments?
Yeah. So I will tackle the study design piece first. So, I mean, obviously there are choices here that needs to be made. And so we sort of started using the summary statement to guide us a little bit, because the purpose here is to try to obtain funding. But we also absolutely agree with you, Christine, is to be able to still preserve the original spirit, if you will, of the intervention. And so so it's sort of the balance between these two things. But for our particular example, thankfully, we did not receive too many sort of weakness comments, if you will, in terms of the intervention content itself. So the actual refinement there is very minimal. So we were able to retain sort of the spirit of that. If you, in my, you know, just thinking about if the other option, if you did get a lot of feedback about your overall study design or framework that you use to develop your design, I think it's sort of the skill set of being able to take as much as you can from the summary statement and the reviewer's comments, other people's feedback as well, but also be able to understand that you don't have to do everything, I guess, if you will. But so for me, it's being able to think through with the team, having discussions with people that will help with this process, and be able to think about what needs to be fixed based on comments, but also what are the comments that we perhaps don't really need to, you know, make too many changes on right now. So that's I don't know about you, but that's sort of the balance between these things. It can, you know, it's always something that we need to take into account. I hope that answers the first question. And then the second question in terms of the persistence. So I will just share a little bit more. So now I don't know if this is this is the reason why we when we submitted our first R01, which was a 13th percentile scored R01, and then after that, I think NIH and the CSR went through a major overhaul of their study section. So we actually went to a different study section, and got the 24th percentile, which is not bad again, you know. And then with our new 01 application, we went back to the second study section, and that was where we got the not discussed. So it's being mindful of that process as well. It's and also you know, just thinking about, you know, what, you know, perhaps, you know, it's the science, but it's also the way we have told our story. And those of us who've written the have submitted grants and have gone through this process understands that you know, the way you tell your story and also the psychodynamic of the review sections can be very important too. And so as we think about regrouping, we are thinking about all of these things as well. And in my experience, and just to share that absolutely persistence is key. I have other projects where it's gone through 2 or 3 different cycles of an R01, and then finally getting funded. So it does get my experience as you go through all of the review sections, and at some point, you know, success will happen. And I keep hearing this from a lot of people too. And so I think the persistence piece is very important. Don't give up. Don't ever give up. Sometimes, yes, if you need to set it aside for a couple of days and maybe punch a pillow or something, and then come back to it, kind of that's okay, but don't. And sometimes it's also the timing and sometimes the program enhancement and the funding opportunity as well. So, be able to be thinking about all of these things as well. Maybe there's another opportunity that came up that would fit your design. That would be a good place to try. And so, all of these things are things that we think about as a team in terms of persistence. So, but truly, sometimes it may take a little bit of time. Sometimes you may need to set it aside for a little bit, but don't give up, because it does, in my experience, and I hear from other people too, this whole process, it does make things better. I mean, the strength of your the science, and also the way the story is being told in your application, and at some point, timing and everything aligned, things will happen. So yeah. So definitely persistence is key. Absolutely.
So Virginia, I just want to reiterate a couple of things that you mentioned that are so important. And number one is that study sections matter.
Yes.
Newly formed study sections often have not developed a groove, so to speak, and they can often have more sometimes more divergent views that are represented in a study section until people have sort of become more aligned. And that's kind of a sort of timing issue that you often don't have any control over.
Yep.
And it highlights again the importance of persevering and, in a way, almost getting to know the study section so that you can speak to their particular concerns, and so that your story, the narrative that you just described, Virginia, is something they can understand and hear. So being aware of the study section, using the ART tool that NIH has to try to at least get some alignment with your study section if you're given that opportunity, is important. And then the second is really around perseverance. And I think the perseverance works better with the team and with community. So not to go socially isolate, but to actually reconnect with those that are your support team, both scientifically and non-scientifically, so that you can, muster up the strength to continue. So last question to end on, did any of these experiences lead you to temporarily question your career goals and aspirations? And I think this is such a great question, because I think I do hear a lot of people say this, which is sometimes people take these scores personally and say, maybe I'm not cut out to be an academic researcher. So tell us your thoughts about that.
Yeah. So I don't think there's definitely times where you're kind of rethinking, what's going on here, because it is not easy. It's never easy to sort of get a score like this, and it hit us hard too. I would just tell you, I've gotten in my experience now a lot of no's, but it's never easy to just get to see your score. But I would, but it does get better as you do this more and more often. It does get better in my experience. And so so don't, don't give up on that. And I think it's good. I would definitely underscore, Christine, your thought in terms of having a community, people that you can debrief with, that can support you, because we all need that. This is not an easy journey for anyone, whether it's a junior investigator or a senior person. I know many senior investigators who are very well established that experience this as well. And so so that community is very, very important. I think this is a community for us. It's so great to have PCRC being a community, these webinars and the connections that we have. We can be this is our community for us in terms of everything related to palliative care. So for me, I think for me and for everyone here, when you get to that point, just set it aside, reach out to people, your community, right? And debrief, punch a pillow, whatever you need to do. Go take a hike. For me, hiking does help clear my mind, and then regroup. If it takes you a couple of days, that's okay, right? Because I think walking away from it sometimes does help. and you can come back with a clear mind, you know, having debriefed with people that you trust, your community, your support, and then be able to come together with your community and your team and think about what to do. You know, what is our next step? And so I would say community is very, very important. Let's, you know, sort
What
of.
a great way to
Yeah.
end a really important and inspiring webinar. Thank you so much, Dr. Sun. And I'll turn it over to Naomi to tell you about next month's webinar.
Thank you so much, Dr. Sun and Dr. Ritchie, and to everyone who joined us today for our webinar. Stay tuned for an evaluation that's coming in through your email. It's very brief, and we'd love to hear any suggestions for future webinars. And next month, we have Doctors Joe Wenger and a PCRC biostatistician Greg Samsa presenting Designing Persuasive Psychosocial Intervention Pilot Studies, a tutorial for palliative care investigators. Please do visit the website to register. And any other questions, please feel free to reach out to the pcrc@ucdenver.edu email. Thank you again, everyone, and have a great rest of your day.